Hello, everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled, Frankly Speaking About Cancer, Bladder Cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. And that includes patients and caregivers, their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, you can visit our website at www.cancersupportla.org. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter any questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but our presenter has shared his contact information, and his contact information will be on the slides, and we can send you the slides at the end of this webinar. So I'll go ahead and introduce our speaker now. Dr. Peter Wu understands the challenges of living with bladder cancer, having dedicated his career to helping patients with prostate and bladder cancers. He received his medical training at NYU Langone Health, honing his skills at one of the nation's premier academic medical centers. Additionally, Dr. Wu completed a brachytherapy training at Memorial Sloan Kettering Cancer Center, gaining expertise in this targeted radiation technique. With over 2 decades of experience researching and treating genitourinary cancers, Dr. Wu has co-authored numerous studies on improving radiotherapy outcomes. His specialized training and expertise uniquely equip him to provide the latest treatment options to maximize quality of life. As a family man himself, Dr. Wu is the proud father of 2 young boys and lives in Temple City. And it gives me great pleasure to welcome today's speaker, Dr. Wu. Please join us.
Oh, hi, Kathy. Thank you for the very generous and nice introduction. It's my pleasure to present on this topic, which is very close to my heart, bladder cancer. A little bit more about myself. I'm from New York City. Just a few months ago, as you know, I did much of my training at NYU and Memorial, and you know, we like to tell jokes in New York City. So if you came looking for bladder jokes, you're in luck. You're in luck. Okay, well, this is no laughing bladder. Let's get to it. This presentation will cover the basics of bladder cancer, including staging, treatment options, and side effect management. I want to emphasize that the stage and options for bladder cancer are intrinsically linked, and we will not be able to get into every single treatment option, but kind of make a sketch of what the possible treatment options are. And I'm very happy answer further questions during the QA and also later on. But another very important second part of this presentation is to highlight the importance of the survivorship and also community support resources that are available to you as bladder cancer patients, as well as survivors, as well as family members through the cancer support community, Gilda's Club, and other supports networks. It lets you become knowledgeable, it helps you take action, and helps you utilize community support. So again, this is me. If you ever want to reach me, this is my email address, and this is the number to my office. It doesn't go to a call center, it goes straight to my front desk, and they'll be very happy to connect you with me in a more formal setting. But informally, feel free to just email. I'm very accessible, and I welcome it. It's why I became a doctor. It's to take care of people and also help those who were suffering. Even with questions that may seem minor to you, I'm very happy to answer it. I have no financial disclosures. I am, but if you'd like to involve me in any financially advantageous things, let me know. As Kathy had described, we're part of this this presentation sponsored by the Cancer Support Community. It's a wonderful community in partnership, actually merged with Gilda's Club in 2010, that really promotes the power and of cancer communities. And one of their taglines is that community is stronger than cancer. So hats off to the Cancer Support Community for bringing all of the stakeholders and resources together for this presentation. Let's get into it. Bladder cancer. Bladder cancer. You know, it's reminds me of a joke. There's a man who was 60 years old and he began to have bladder problems, and he goes to his friend who's 80 years old and says, I have an awful time with my bladder. I have to go all the time. And sometimes it comes pretty suddenly. I don't have time to wait. How are you? And he goes, the 80-year-old goes, oh, I've got no problem at all. My bladder works fine. Every morning I'm like clockwork. I go to the bathroom at 7 a.m. and it works perfectly. I only wish I woke up before 8 a.m. And so bladder cancer, again, no laughing matter, but it's an important topic to keep on our minds, because it's something that many people face as they grow older, and bladder issues in themselves. Anyways, bladder cancer. So today we're going to talk about bladder cancer. We're going to understand the treatment options. We're going to spend a little bit of time discussing the basics, and we'll focus more time on the mental, physical, and emotional effects of bladder cancer, and on those who are diagnosed with it and the survivors. And we will even talk about how to care for the caregivers as well. Again, this is more introduction to our local chapter of the Cancer Support Community within Los Angeles. They're an excellent group. They've been around for more than 40 years, and they're a key part in helping those who have been affected by cancer, not only patients, but also caregivers too. Let's jump right into it. So here's the bladder. The bladder is a hollow muscle that stores urine until it's passed through the urethra, and the urethra is this tube that either passes through the vagina or the vaginal canal, I should say, or the penile canal to exit the body. In this example, this is a man. Here's his prostate. The inside layer of the bladder is often where bladder cancer occurs. It's very common for bladder cancer to happen here, but some people may not have bladder cancer of the urothelial lining. Some people may have bladder cancer of the muscle. Some people may have bladder cancer of the urethra itself. These are all forms of bladder cancer. Outside of the inside lining is the connective tissue. Connective tissue is a place where the bladder cancer can occur too. The deepest type of bladder cancer, the one that is here in the lining, is squamous cell cancer. It's very common again, and also somewhat aggressive. When you have squamous cell cancer, it's oftentimes best treated with surgery because it very rarely stays within the lining. The second type of bladder cancer that can occur in the lining is called urothelial bladder cancer, which is also very common. Many of times these stay within the lining of the bladder and can be treated with intravesicular therapies like BCG or mitomycin C, and sometimes surgery is not even necessary. And finally, again, in the deeper layers near the muscle, there's something called adenocarcinoma of the bladder, which is least common, but it is also there. So outside of the glandular tissue and the muscle, there is a layer of fat. The fat in this gentleman is very limited. In myself, it is very voluminous. Yeah, but the bladder is suspended in a layer of pelvic fat. And outside of that, further is the psoas muscle and various other muscles of the pelvis. Cancer of any type forms when there's too many genetic errors. Genetic errors are caused in two ways. One, you inherit them. You're born with them. And it happens not from your own fault. The other is through environmental factors. And in the case of bladder cancer, the most common environmental factor is smoking. The second most common is actually people who work in the dye industry. I had a very interesting patient who printed the very first lottery ticket in New Jersey, and he never smoked a day in his life, but he had bladder cancer in his 90s, and we suspect it's due to all of the various dyes he was exposed to as a lottery ticket printer. There's other factors that cause genetic errors within the bladder in third world countries, such as schistosomiasis, a parasite that can get into your bladder. But those are what causes bladder cancer: genetic errors from various types of insults, smoking, dyes, and also printing dyes, and schistosomiasis parasites. As the cancer grows and divides, it will begin to form a tumor. That's true for all cancers. Let's go down one level even deeper. Let's talk about some definitions of various terms, things that you may have heard at your doctor's office that may have not been defined very well. Chemo, everyone knows chemo. We can skip over that. It's a type of drug that is used to kill cells, but also kills normal cells too. It's what you think of when you think of chemotherapy. Targeted therapies is very new. It's not chemotherapy, and there are many drugs within bladder cancer specifically and urothelial cancers that target specific genes, like FGFR3, for example. I'm not going to name any specific drugs. I think that's not appropriate for this presentation, but targeted therapy is up and coming in bladder cancer and urothelial cancers, and they do not cause the same side effects because they target a specific gene, and they're designed to block cancer growth driven by these specific genes. And so you don't have to lose your hair. You don't have to even have an immunosuppressed immune system. Radiation therapy, that's something that I'm quite skilled in and have quite a lot of experience in. It's the use of X-rays to treat cancer and also stop cell division. X-rays have a great advantage over chemotherapy in that they don't affect any part of the body except where they're used. So for localized disease, for disease that is not spread, radiation therapy is an excellent choice. And oftentimes, urothelial carcinomas of the bladder, the inside lining, like we're talking about, are quite localized. Immunotherapy. Immunotherapy has won the Nobel Prize very recently in the 20, I think it was 2017, 2018. But immunotherapy has been used in bladder cancer for decades. It was one of the first subsites of cancer that utilized our own immune system to fight cancer. These drugs work in different ways. Some boost the immune system, others irritate the bladder lining in order to stimulate an immune response. It's really quite very trailblazing that we have been using immunotherapy in bladder cancer for quite a while. But again, immunotherapy is using your own immune system to fight, attack, and kill cancer cells. Maintenance therapy. This is something that is often done after radiation therapy or after surgery to prevent the cancer from coming back. Maintenance therapy can also be done after chemotherapy too. It is a phase of therapy. It is not a type of therapy, but a phase of therapy. There's usually an initial therapy followed by maintenance therapy. It is used to prevent the regrowth of cancer cells, and it is used usually during this treatment of higher stage tumors, stage 3, stage 4, that have a high risk of coming back. Lower stage tumors and also lower risk tumors oftentimes are cured and watched, surveyed, instead of treated with maintenance therapy after surgery alone, radiation alone, or immunotherapy alone. Next word is clinical trial. We all know what clinical trial is. They're experiments done on specific types or stages of cancer in order to find something new. It may be a new way of diagnosing it, maybe a new way of treating it. Cystectomy. Cystectomy is the surgery to remove the bladder. It is a cancer treatment surgery. It is not to be done lightly. However, some wonderful surgeons are out there and they can create new bladders out of various tissues. So it doesn't have to change your quality of life forever. The cystectomy is often followed by a reconstruction and a temporary urostomy. Oh, that's the next word. Urostomy is an opening within your abdomen in order to help direct the urine away. Now I've been going through these definitions a lot, so oops, there we go. Here, I'm going to my list of jokes again. Speaking of urostomies, have you heard of the new series on Netflix about urostomy? Yes, it streams nightly. You get it? Okay. Well, in any case, urostomies are sometimes even more convenient than having a bladder, in the sense that many people pee into a external bag, and it oftentimes allows urine to exit the body without the use of a bladder. Many times urostomies are necessary for bladder cancer treatment, and they can be temporary as well. Finally, this is a interesting term that is becoming more and more important in the last few years, since immunotherapy, specifically PD-L1 or programmed death ligand 1 directed immunotherapy has won the Nobel Prize, and essentially PD-L1 is the biomarker you need in order to use certain types of injectable immunotherapy. It's in plain language, PD-L1 allows the tumors to evade your immune system. It's like a cloaking device. And if you block PD-L1, your immune system is able to see the tumor again. All right. That's a bunch of definitions. I'm tired. I hope you're not tired. But let's keep going. The medicine is a big jargon-filled field. We use words like idiopathic. Yeah, we don't. It just means no one knows what's going on. And so I think it's important to get through the jargon. And also it's important to know the various people on your team. There's a large team of doctors that may come and treat your bladder cancer. You may be used to just having one doctor, a primary care doctor, and all of a sudden you have seven or at least, at least three. I hope you have at least three, a primary care doctor, a medical oncologist, and someone else. But let us talk about all the various members that may or may not be on your team. There's the medical and radiation oncologist, key members of the team. Certainly, if you have bladder cancer, the medical oncologist prescribes chemotherapy, targeted therapy, and immunotherapy, like we talked about, and oftentimes takes charge of maintenance therapy. The radiation oncologist oftentimes is interchangeable, or at least oftentimes comes after surgery. So the surgeons involved with bladder cancer are called urologists. Urologists are surgery doctors, surgeons who specifically train in treatment of kidney, ureter, bladder, and urethral issues. Some are even subspecialized in urologic surgery only, so surgery of the bladder, the kidney, the ureters, and the urethra. It's really critical to feel confident in these three gentlemen or ladies who are treating you. They are the three pillars of care in bladder cancer: medical, radiation, and surgery. It's kind of a rehash of what we just talked about. I'm sorry, I apologize. Very important. In fact, more important than these doctors. These doctors, more important than them are our wonderful nurses. They are truly the ones who take care of the clinic and also take care of our wonderful patients. Each of these groups will have a nurse, and if you end up with a urostomy, something that hangs out of your body to drain the urine, there may be wound ostomy nurses as well to help take care of that. Nurses are incredibly important parts of the team. For late stage patients, palliative care specialists may also be involved, especially if you're highly symptomatic and need assistance with those symptoms. Physical therapists can be very important, especially after deconditioning from chemotherapy and radiation and also surgery. Dietitians are very important as well. It's important to have a diet that suits wound healing, a diet that suits healing from surgery, and a diet that helps overcome all of these side effects, especially nausea of chemotherapy, so you don't lose weight. Finally, social workers. They are really the angels of the hospital and or community center. I call them the moral compass. They do the right thing at all times for the patient, and they can help oftentimes with things that are really quite important. Healthcare advocacy, proxies, time off from work, FMLA, transportation. Invite them into your care team if you have the privilege of meeting one. Finally, there's patient and financial navigators. Bladder cancer is not just toxic to treat, it is also financially toxic. And coming from an immigrant background myself and knowing hard times, it's not easy to go through any sort of struggle and then have financial struggle on top of it. So please invite them into your care team if you have that opportunity. Another break, because that's another mountain of words. Let's say another joke. What do you call a soul singer with a bladder problem? You give up? It's Urethra Franklin. You get it? Urethra Franklin. Okay, why is cancer staging necessary? Well, cancer staging is the hallmark of how we choose treatment, and is also a hallmark of communication between doctors and also other healthcare professionals. Stage 1 cancer, stage 1 throughout the world. Stage 2 cancer, stage 2 cancer throughout the world. And it's recommended that you have a very important important understanding of your own stage, because cancer staging is vastly, treatment is vastly different based upon stage. We won't get into staging here. It is quite technical, but ask your doctor, what stage are you? I'll help you in the next few minutes. I hope you better understand staging and the options that are standard of care for each stage. One quick question is, can the stage of bladder cancer change over time? In the technical sense, no. You are staged as you are diagnosed at the very beginning of your diagnosis. Usually staging is done with a radiologic study like a CT scan. Some people have recurrent disease or disease that progresses, but you're still the same stage. However, the prognosis can change over time. Even though you're the same stage, for example, you're stage 1 and then unfortunately you have recurrence elsewhere, then you are, recurrent stage 1 with metastasis to the bone, for example, you're still stage 1. What diagnostic tests did you perform that helped you understand the staging of my bladder cancer? That's another common question. The most common diagnostic testing that is done is usually a CT scan. You might ask, why not a PET scan? Well, it's because PET scans are not suited for bladder cancer. The PET tracer stays within the bladder and causes the bladder to be opaque, so that you can't really tell if it's cancer or just radiotracer inside of the bladder. The better test is a CT urogram, or even better than that, a cystoscopy, something that a urologist can do to look inside the bladder and see exactly what's going on. Blood work is quite important for bladder cancer for many reasons. It helps us assess your fitness for chemotherapy, surgery, and radiation. And furthermore, there are certain blood tests now that can even look for circulating tumor cells, circulating tumor DNA, CTCs or ctDNA within your body to track whether you are having a response to treatment. So blood work is very important. Oh yes, the big $1 million question: how does stage impact cancer treatment options? So let's just go forward. Stage 0. Stage 0 is called carcinoma in situ. That's usually treated with something quite local. It can often treated with what's called a transurethral bladder surgery, or TURBT, transurethral resection of bladder tumor alone. These carcinoma in situ do not invade. They are non-muscle invasive, and they are stage 0. So they're often just treated with a little bit of a resection, and that's it. Stage 1 oftentimes requires TURBT, which is what we talked about, a transurethral resection of bladder tumor, and sometimes afterwards a little bit of a installation of either immunotherapy or chemotherapy. Here is a example of the surgery itself. This is the resectoscope that is added to the cystoscope. It's truly, it kind of looks like a lawnmower from the inside out. There's a rotor that goes, and you can obliterate or macerate, is a scientific term, any tumor that you see that's visible until you reach the layer of the muscle. So you really resect and destroy any tumor within the urothelial lining. This is also diagnostic too, to see if anyone has bladder cancer. The resectoscope will remove any abnormal tissue, and the side effects of a surgery like this, called TURBT, or transurethral resection of bladder tumor, includes mild bleeding and pain during urination, but this often goes on only for a few days, and you can go home the same day. Again, for stage 1 tumors, sometimes installations of chemotherapy, not systemic chemotherapy, not stuff you get in your veins, but mitomycin C inside the bladder sometimes helps, or maintenance BCG therapy, which means getting a little bit of the BCG vaccine. What I forgot this, but Bacillin Curie Guillain. I think that's what it stands for. It's two French people, and I think this stands for bacteria in France. But in any case, this is the TB vaccine. This is one of the very first TB vaccines. The BCG vaccine can be instilled inside the bladder, and it will cause a immuno reaction using immunotherapy again to treat the bladder cancer. The treatment goal for non-muscle invasive bladder cancer, stage 0 and stage 1, is cure. And that is synonymous with no evidence of disease. If you can't see it, you're cured. And it's the truth for the vast majority of patients. The vast majority of patients are cured. It's really okay to assume that after surgery and or installations of chemo and immunotherapy, that stage 0 and stage 1 bladder cancers can be cured. Stage 2 bladder cancers are a different type of cancer altogether. These are called muscle invasive bladder cancers, and they've gone beyond the inner lining of the bladder into the muscle themselves. Stage 3 is similar, and stage 3B is similar, and stage 4A is similar. They have to do with different levels of invasion of the muscle. Stage 4 being truly, invasion of not only the muscle, but the fat, and sometimes even the various organs like the rectum or the prostate or the uterus in females. These are much more tricky to treat, and they involve a combination therapy, which does not exclude chemotherapy. I think that is the best way to put it in one big basket, a combination of radiation, surgery, and chemotherapy, but most often it always involves some sort of systemic therapy, oftentimes chemotherapy. Many patients can be treated without surgery. It's because surgery is very difficult for people over the age of 80, especially removal of your bladder. If your bladder is working just fine and you have bladder cancer, sometimes radiation and chemotherapy can be combined to cause the bladder cancer to shrink and oftentimes disappear completely. This is especially effective for patients with squamous cell cancers of the bladder. You can ask me more questions about it later, but that is one of our active areas of clinical investigation, and also very exciting treatment options, because people get to keep their bladder. Who doesn't want to keep your bladder? You've had it for all your life. You want to keep it, right? This reminds me of a joke. So a man was going to the bathroom, and he realized that he was rushing to the bathroom, and when he finished, he was Finnish, and while he was inside, what was he doing? He was European. You get it? Russian, Finnish, European. Okay, that was a bad joke. I'll do better next time. Anyways, hope everyone's still awake. This is quite boring stuff. Moving on, stage 4B bladder cancer is metastatic bladder cancer. Unfortunately, at this stage, bladder cancer cannot be cured, but it can still be treated, and you can have meaningful improvements in your quality of life as well as overall survival. And it's important to not give up hope, but to continue to live your life as best as possible, and also go for treatments which are very effective. Immunotherapy has revolutionized the treatment of metastatic bladder cancer. Many patients live a long, long time, longer than we've ever seen, sometimes over a decade. Of course, they're very tippy-top cases, but they're often treated first and foremost with immunotherapy, targeted agents, and chemotherapy. And then, if there's problems, bleeding, difficulty urinating, local therapies like surgery and radiation can be considered for palliation, meaning to help with the symptoms. For muscle invasive cancers, we already went over this a little bit. The mainstay of therapy is removal of the bladder. Sometimes part of the bladder can be removed when it is mostly confined to the left side or mostly confined to the right side of the bladder, and it is really small, perhaps less than 4 centimeters or 3 centimeters. The advantage of that is you keep your bladder. But most of the time it is a removal of the whole bladder, which is called a radical cystectomy. Oftentimes this procedure is necessary to prevent recurrence, and it is a heavy burden upon the patient because there is a big surgery and afterwards a reconstruction. For women, oftentimes the ovaries, fallopian tubes, uterus, cervix, and the upper part of the vagina are removed. For men, the prostate and the seminal vesicles are removed at the same time. Again, after muscle invasive, stage 2 and above bladder cancer, chemotherapy is a mainstay of treatment, and immunotherapy and targeted therapies can be introduced as well, depending on the stage. Higher stages tend to require more intensive systemic therapies. The treatment goal in muscle invasive and bladder cancer, I would disagree a little bit with this slide. The treatment goal for many muscle invasive bladder cancer is cure. It is not to slow the spread of cancer. It is to cure you, and you should still have hope and also intent to find a cure. The treatment goal for metastatic bladder cancer, however, is this slide. Slow the spread of cancer, limit the tumor growth, extend your life, and also have a good quality of life. The symptoms must be managed well, and you have to have a good quality of life. You can't just live with a bad quality of life. Oftentimes, again, after being diagnosed with metastatic and/or advanced risk, advanced stage bladder cancers, you have to do some sort of maintenance therapy to lower your risk of recurrence. The risk of recurrence is oftentimes done through increased in muscle invasive bladder cancers. Non-muscle invasive bladder cancers, you sometimes do a little bit of BCG installations, but sometimes surgery is all you need. For metastatic bladder cancers, you do need maintenance therapy for the rest of your life. It's to prevent the tumor from coming back. It can be chemotherapy or immunotherapy. Can treatment options change over time? Yes, they can. They can be changing over time. And, it's 2023 right now. In 2020 or 2003, when I first got into, medicine and such, the landscape has changed completely. It's completely. And so in 2033, the treatment options will be very different too. So this provides hope for patients with stage 4, 4B bladder cancers. There are more options coming, especially for targeted therapies and immunotherapies. So let's talk about what you can do. This is the second part of the presentation. I think I've actually gone over time, so I'll go over this a little more cursorily, but this is just as important. What can you do as a patient at your doctor's appointment? Now that you've been empowered by all this information, make sure you gain control and maintain control of your healthcare. Ask the hard questions. What stage am I? What are the side effects of treatment? What is important about what you're giving me? Ask about any symptoms you have. Ask about the latest information about clinical trials. Ask questions until you fully understand what you're being told. You can even ask for different languages. You can ask for a drawing if you need it. Make sure you really advocate for yourself and ask as many questions as you want of your care provider. And if they are annoyed by it, you got the wrong care provider. They shouldn't be annoyed by it. They should treat you like their best friend. Sometimes they may not have time, and they'll just schedule another appointment with you, but they just ask as many questions as you can so that you have control over your own healthcare. Sometimes it is overwhelming. You don't want to know all this stuff, and that's okay. That's when you have a caregiver. You have a caregiver who is a loved one, or maybe is your spouse, and they can do all this, take notes, gain and maintain control of your care, and also take care of you at the same time and shield you from all these things. But you got to have someone. You got to have someone helping you with that. Here are lots of questions that are available. There's a website with a list of questions you can ask, and I think these can be made available to you later on. This is the Institute of Medicine list of questions. Before you go into any doctor's meeting, it's important to know, like, what is most important to you. Is it your family? Is it your job? Is it both? Is it in equal amounts? Also, know how this is going to affect your relationships with your family, and really think about how it's going to affect your work. Can you adjust your schedule, or are you inflexible? These are things to tell your provider right away. And they're very interested. We are very interested in knowing, because in the end, we're not treating a disease, we're treating a person. And you as a person have many facets to you besides bladder cancer. And these facets sometimes oversee the cancer itself. It's like, I had a patient who had metastatic bladder cancer. He was a young man in his 50s, and he was a video game player, and he really wanted to continue playing video games, but he had metastatic disease in his fingers. So we gave him radiation to his fingers. It was a very strange thing, but it allowed him to continue playing video games. Many people may not have entertained that, but it was the right thing to do for this gentleman. Again, we're a little short on time. I apologize. If you don't find your caretaker to be satisfactory, you should get a second opinion. Second opinions are paid for by Medicare. They're okay. They're paid for by your insurance. Go get one. And it's okay to seek a second opinion or change doctors at any point. If your situation changes, if you move, or if you need a different level of care, if you have just been diagnosed with metastatic recurrence, for example. This is a video. I think we're going to skip the video. One of the most important reasons to get a second opinion is to get clinical trials. Clinical trials are available at different institutions, and they are different at each institution. They provide an opportunity for patients like yourself to access new therapies and the next generation of treatments. They are not necessarily better. And please know that. They are just different and new. They are not standard of care. They're different and new. New is not always better. New is not always more effective, but truly you're contributing to science with your enrollment in a clinical trial, and that is something that many people seek to give back to science. By joining a trial, you can help move cancer treatments forward and provide real hope for others and yourself in the future. It's a good option for those who have rare or aggressive tumors, or those who are interested in helping other cancer patients. It's also very important for those who are no longer responding to other treatments. So ask about clinical trials. And finally, also very important is the community in which you are in. We're here to support you. I'm part of the community as a doctor, but also part of the community as somebody who wants to support cancer patients, having known many a cancer patient, their families, and things that go on. There's a lot of challenges that go on within the family. There's loss of control, unwanted loneliness, living with uncertainty, and you can't do this alone. Gosh, these slides are a little bit out of order, but let's skip to the community resources. There we go. First and foremost, it's important to take good care of yourself and maintain physical wellness. The CER is a survey of cancer patients that focuses on really the symptoms and quality of life of cancer after diagnosis. 56% of patients in the survey were moderately or severely concerned about eating and nutrition. 51% were concerned about exercising, being physically active after diagnosis. And so it's very important to be very mindful of your diet and exercise. There are many individuals who are there to help you: nutritionists, physical therapists. Physical therapists help strengthen your affected muscles, help with bladder training, especially if you had a reconstructed bladder, help you regain confidence. More importantly, 42% of cancer patients who had bladder cancer were concerned about walking, climbing. The physical therapist can help with that. Incontinent diversion or continent diversion using a urostomy or neobladder often requires heavy physical therapy. Is in a cystectomy, and also, pardon me, there's a lot of side effects that happen with respect to a surgery, and also chemotherapy and radiation. Lots of changes to your body image as well. Again, we draw upon not just your doctors, but many allied healthcare providers and the community for all of these issues. For survivors, there's a lot of issues with sexuality and intimacy, as cystectomy and also other treatments like chemotherapy and radiation affect one's ability. For men, for example, removal of the prostate it entails oftentimes sexual dysfunction, and for women, removal of part of the vagina causes sexual dysfunction as well. And so you must take good care of yourself by involving as many of our community resources as well as your allied health professionals, counselors, social workers, for this. Resting a bit on this slide because it's really underspoken, it's really under reported and under discussed. The most important step to achieving intimacy again after any treatment is patience and understanding. It's important to mentally adjust to your new body, and also mentally think about the losses that you have had and accept that you can still be intimate, although in different ways, and or maybe with different strategies. And that's something that I cannot emphasize enough. So moving on, when you have cancer and you have a lot of things happening to you all at once, it's easy to be overwhelmed. Anxiety, depression, isolation, very common. I always ask my patients, do you cry at home? Are you okay? And you can do a lot for it. You can do things you enjoy, but you can also join a support group. You can work with a therapist. And sometimes the best therapist is your spouse, because they love you and they'll tell you what you need to hear straight. Join a support group and find a therapist if you're feeling depressed. And finally, financially, there's a whole gamut of people who are there to help you with the financial toxicity of treatment. It's really a important aspect of treatment to find yourself on the other side, able to achieve your financial goals. Who cares if you're cured of bladder cancer if afterwards you're saddled in decades of debt? It's like it's not right. It's not right. So reach out to financial counselors. I'm really going over time now, so I encourage you to really let me just look at the most important slides. Palliative care is quite important for patients with stage 4 and also those with heavy symptom burdens from bladder cancer. The palliative care team is another community resource, another allied health professional that helps with this. There's dedicated doctors, nurses, nurse practitioners, PAs, and other caregivers who specifically help with cancer symptom treatment and also other symptom treatment. It's based on the needs of individual, and they will try and help you achieve your goals. It's not about getting cured or any medical outcome, but rather how are you feeling and making you improve your quality of life, please include palliative care in your treatment team. Caring for caregivers is really important. They're people taking care of you, and they need taken care of too. So in the same way, a multitude of challenges can be put upon your caregivers. So caregivers who are listening to this, set limits, pace yourself, don't burn out. Your patient or your loved one needs you, but you need to be also prioritizing your own needs. Keep tasks realistic, retain flexibility. You may even choose to seek support from oncology social workers, therapists, clergy. You may turn to support groups. There's a lot of resources, including the ones offered by the Cancer Support Committee for caregivers. There's another organization called Caregiver Action Network that has caregiver resources. Once you have an understanding of the support system and your resources, you can see how much you can actually give. And once you reach those limits, set limits for yourself and define them, and don't cross them. That way, your needs can be a priority too. Again, there are caregiver support groups, religious leaders, and others that might help. Caring from a distance is very challenging, and it's important to understand that you have to have a list of contacts for emergencies that may be better to contact than you're caring from a distant caretaker. Sometimes it's important to have somebody in person. It's a lot of care that must be done, and coming from a distance is sometimes even more difficult than being at the side of your loved one. Don't rush decisions when you're coming from a distance. Really listen and seek help when you need it. So this concludes our presentation. I just want to give a few more slides highlighting the resources specific to the cancer support community. There's the Cancer Support Helpline. Here's the number. It's available, and you can also make appointments by calling this number for help with treatment decisions and other specialists that are employed by your local CSC and Gildas Club staff. The number again is 888-793-9355. Bladder Cancer Advocacy Network has specialized resources for bladder cancer. Here's their number and their website. My Lifeline is yet another excellent resource that you can use to connect with others, to find hope and exchange ideas and share stories about what you're going through, about your specific cancer. They have many communities for different cancers. And again, the Cancer Experience Registry that we just discussed is a great resource for other cancer patients that both provides physical as well as emotional and psychosocial support, and helps you connect with the responses from other cancer patients. Finally, if you want to join us, if you want to join the cancer support community and become an advocate, there are opportunities to advocate at Capitol Hill and also have your voice heard alongside voices of thousands of other patients. We live in a democracy. This is how we get things done. So thank you so much. I really appreciate the opportunity to present to everybody. And one last joke. What do you call an accountant taking a pee? Get it? Math whiz. A math whiz. All right. Thank you, everybody. And parts of this presentation were also supported by Pfizer and EMD Serrano. I think that is the final slide. But let's open the forum for any questions and answers. I apologize, I've gotten a little over time.
Dr. Wu, that's okay. I think we have time for a couple of questions. So we did have a question that came in the Q&A feature. And if you do have a question for Dr. Wu, please go ahead and type your question into that Q&A feature. The question that came in, and perhaps you're seeing it as well, but someone who had microscopic blood found in urine during a couple of annual physical exams, so 2 years in a row, and is getting a second opinion from a urologist. What are some important questions for this individual to ask?
You know, microscopic blood is really very concerning in any form, but I'm glad that you've had all of the great tests, an MRI, an ultrasound, cystoscopy. I would feel reassured. I think that you should ask your providers this question. What is, and here's a special term, differential diagnosis. That's a technical term, which means what do you think is going on? Number 1, 2, 3, 4, and 5, and give me the percentages for each of them. I sense that maybe your microscopic blood may be due to, it could be due to early diabetes. It could also be due to some leakage of blood in your kidneys. The key finding in bladder cancer is gross hematuria. That's when you see the blood. It's macroscopic. So microscopic blood doesn't necessarily mean bladder cancer.
Great. And then an additional question is, you mentioned to ask your doctor what stage you are at diagnosis. What are some other important questions to ask when you are newly diagnosed with bladder cancer?
Great question. Stage really drives much of the treatment. I think if you are stage 3 or 4, the treatment algorithms are not so clear cut, especially if in the second and third line treatments. It's important to ask your doctor, what are my options for treatment? What is the standard of care and what clinical trials are available? You'll find, I think surprisingly, that there's not just one way to do things. And it's important to understand in detail the risks and benefits of each option available to you. Upfront therapy is often very straightforward, and perhaps it's a waste of time, or not waste of time, but it's less productive to ask about all your options. But if you are later stage, ask about the options. Bladder cancer is complicated in the later stages, and there are many options.
And then I think a final question in closing. What are the late effects, if any, of treatment for bladder cancer?
There are, again, many different types of treatment, and the late effects themselves vary by treatment. I think the most influential ones are the ones that we settled a little time on during this presentation. And the sexual side effects are great. They're large, I should say. They're not great. There's many of them because it involves removal of many important sexual organs, and that's not talked about a lot. The bladder dysfunction that comes from any sort of treatment is also important to note, because it's not the same to have a neobladder, nor is it the same to have a bladder that's gone through radiation or gone through partial resection. Incontinence, difficulty urinating, pain with sex. These are all challenges that many people with bladder cancer will live with, even with successful therapy. And involve your physical therapists, involve those occupational therapists, involve other allied healthcare professionals in your recovery process. It will really help.
Wonderful. Thank you. Well, Dr. Wu, we just thank you so much for your presentation. I know I learned much as well as others did, I'm sure. And we've reached the end of our time together. And I would like to thank Dr. Wu for his time today and for sharing his expertise with us. I also want to thank our attendees for your engagement with us today on this important topic. We will be sending you a survey and would love for you to fill that out. It helps us learn more about programs like this one, learn more about you and how we can improve our programs. We'll also be making a copy of today's slides available. So if you would like to receive a copy of today's slides, you can email us at info@cancersupportla.org. And then to learn more about cancer support community, visit our website at www.cancersupportla.org. Thank you everyone for your great attention and for attending, and we'll see you at the next webinar.